And I realize that, the term flexibility is very vague and oftentimes even misunderstood. But the fact is, representing a rural constituency, I know that things are done differently in rural America, and oftentimes more efficiently. But supply of health care means mere access in rural areas, and it means more competition in urban areas. And so in trying to balance many of those things, I was wondering if Chairman Hackbarth, if you could reflect a bit on the impact to rural communities, rural health care, in terms of recognizing some of those differences that are out there. I mean, it amazes me how we empower medical professionals to make very intricate decisions based on their expertise, and yet in other areas of healthcare we don't allow the judgment to be utilized of the very same medical professionals.
Mm-hmm. So you're talking, Mr. Smith, more broadly about Medicare,
Sure,
as opposed to just within Medicare benefit design.
Right.
How do we, well, as you well know, Medicare has a large number of special provisions related to rural providers, and tries to address the unique needs of rural providers. For example, ensuring access to care for beneficiaries in isolated areas through the Critical Access Hospital Program. One of the areas that we've started to look into a little bit, based on the interest of one of our commissioners who practices in South Dakota, is that medical professionals and staff are used differently in isolated rural facilities than they may be in an urban facility. And
it would seem to me that oftentimes that is undermined given a one-size-fits-all approach coming from Washington.
Exactly. So I think that's one area to look at, and we've just begun to pay some attention to that. But we need to make adjustments to accommodate the unique circumstances that exist in, say, an isolated rural hospital, and how they configure their staff and how they make decisions.
Okay. Thank you. And Mr. Chairman, I yield back.
Thank you, Mr.